Hi, my name is Nima Sarani, and I am one of the emergency medicine faculty at Kansas University Medical Center. In this presentation, I will discuss the role of MDW as a pragmatic screening tool, decreasing probability of severe infection or risk of sepsis through case presentation. And there are 47 to 50 million sepsis cases per year, which cause at least 11 million deaths per year. That is 1 out of 5 deaths worldwide is due to sepsis. In the United States, there are about 1.7 million adult sepsis cases annually, which contributes to about 270,000 deaths per year. Despite debate over the exact timing of treatment for sepsis, we know that the earlier the treatment, the better the outcome. The table on the left shows that delays to antibiotic administration in septic shock is associated with increase in mortality. Over the first 6 hours after the onset of recurrent or persistent hypotension, each hour of delay in initiation of effective antimicrobial therapy was associated with mean decrease in survival of 7.6%. Figure to the right shows that early initiation of antibiotics for sepsis in general is crucial, and not just sepsis with hypotension. Here, the mortality risk expressed as adjusted odds ratio of death increases with increasing delays in initiation of effective antimicrobial therapy. So, speed in administering the right antibiotic matters, but as we all know, diagnosing sepsis can be very complex, especially when most patients with sepsis present with vague symptoms, which are often missed, leading to worse outcomes. This study looked at septic shock caused by SEP1 definitions over a 2-year period at an urban academic hospital. It showed that the majority of patients with septic shock presented with vague as opposed to explicit symptoms. They defined explicit symptoms, demonstrated in orange, as those symptoms that immediately led the clinician to consider infection. For example, fever, chills, productive cough, and dysuria. They defined vague symptoms, demonstrated in gray, as symptoms which made infection less apparent, such as fatigue, weakness, and abdominal pain without fever. When sepsis was suspected, the ED providers triggered a sepsis flag. As shown on the graph to the right, the sepsis trigger was fired more frequently when the patient's symptoms were explicit. Also, more patients in the vague category did not receive the appropriate antibiotics and also had higher in-hospital mortality. So, not only time to administering the right antibiotic matters, but also sepsis for the most part presents vaguely. On top of all that, CMS closely monitors metric compliance, and fallouts are reported when failure occurs in timely completion of each metric. When you combine these factors, early administration of antibiotics, to a deadly condition that often presents vaguely and a governing body that monitors errors in care, it will likely lead to overprescribing antibiotics. Like all medications, antibiotics have serious adverse effects, which occur in roughly 20% of hospitalized patients who receive them. Multiple side effects are associated with the use of antibiotics. Patients who are unnecessarily exposed to antibiotics are placed at risk for these adverse events with no benefit. The misuse of antibiotics has also contributed to antibiotic resistance, a serious threat to public health. The misuse of antibiotics can adversely impact the health of patients who are not even exposed to them through the spread of resistant organisms and C. diff. Prompt initiation of antibiotics to treat sepsis reduces morbidity and saves lives. However, about 30% of all antibiotics prescribed in the United States acute care hospitals are either unnecessary or suboptimal. More than half of antibiotic prescribing for selected events in hospitals was not consistent with recommended prescribing practices. Antibiotic stewardship was created to measure and improve how antibiotics are prescribed, protecting patients from harms caused by unnecessary antibiotic use, and combat antibiotic resistance. CDC's core elements of antibiotic stewardship offers providers and facilities a set of key principles to guide efforts to improve antibiotic use and advance patient safety. So how do we maintain an appropriate balance? On one side, we have a difficult but deadly condition that requires administering the appropriate antibiotic early, but considering the difficulties in diagnosing and the external pressures can lead to overprescribing. And on the other side, we have numerous adverse effects and antibiotic resistance that can occur with overprescribing. This is where monocyte distribution width can help us in ruling out infection and not administering antibiotics, which we likely would have given otherwise, exposing our patients to adverse events. We understand the value of MDW in acute care setting to help us diagnose sepsis. The study on the left led to MDW's FDA clearance for detection of severe infection and sepsis in the emergency department. It demonstrates a superior AUC on the receiver-operator characteristics curve, especially when compared to other relevant markers. But also, MDW values less than 20 show a high negative predictive value for sepsis. With this in mind, we will begin our clinical case presentation to showcase the utility of MDW's negative predictive value for sepsis. A 63-year-old male brought in by EMS for generalized weakness and fatigue for 1 week. Patient has had decreased appetite for the last 2 weeks, has had intermittent nausea, vomited twice yesterday, mild intermittent abdominal pain, denies change in bowel movement or urination. He denies any fever or chills, denies cough or shortness of breath, and no chest pain. His past medical history includes prostate cancer, urinary retention status post, suprapubic catheter. At 7:08, we have our initial vital signs. Temperature 37.4, blood pressure 122/81, pulse 127, respiratory rate 21, SpO2 97% on room air. His positive physical exam findings included mildly dry mucous membranes, mild tenorous palpation of the periumbilical region, and he was tachycardic with irregular rhythm. At 7:35, EKG demonstrated atrial fibrillation with rapid ventricular rate, or RVR, rate at 130. At 8:10, CBC resulted and showed mild elevation in white count at 13.1. MDW also came back at this time and it was 16.7, not elevated. At 8:35, BNP and lactate came back. BNP showed a creatinine of 2.67, which was an increase from its previous creatinine of 1.03 about a month ago, and its lactate was elevated at 2.8. At 8:38, troponin and BNP came back and they were normal. At 9:35, UA was resulted and it showed WBC 5 to 10, RBC 10 to 20, moderate epithelial cells, Leukocyte esterase was 2+, and there was few bacteria. At this point, the provider started suspecting possibility of urinary tract infection. At 8:55, chest x-ray came back and it showed no acute findings. At 10:43, CT abdomen pelvis came back and it showed no acute findings. The providers decided to do a CT abdomen pelvis considering patient's abdominal pain. This patient was eventually admitted to the hospital, and about 5 days later, the urine cultures were finalized with no growth. At 7:08, initial vital signs demonstrated tachycardia, EKG demonstrating AFib with RVR. Patient received IV fluids and rate control medication, was then admitted to the hospital, and urine cultures eventually demonstrated no growth. Recall that CBC demonstrated an elevated white blood cell count, which plus the patient's tachycardia meant that SIRS criteria was met. SIRS plus elevated lactate and creatinine, signs of end organ injury, and a UA that showed some WBC, some RBC, epithelial cells, but 2+ leukocyte esterase and few bacteria, could be suggestive of urinary tract infection. And this combination could mean that we have urosepsis. The pressure to start antibiotics early and to ensure a fallout does not occur, for the most part, can lead the providers to start broad-spectrum antibiotics despite not having the confidence that an infection truly exists. Recall that urine culture showed no growth after 5 days, and patient did not have a urinary tract infection. But by the time this is recognized, the patient has likely received at least 5 days of broad-spectrum antibiotics. Now let's consider the above scenario, which is what actually took place as we have access to MDW. CBC demonstrated elevated WBC, SIRS criteria was met, plus signs of end organ damage, and an equivocal UA, but with an MDW of 16.7, which has also resulted with our CBC with differential. MDW of 16.7 is less than the 20 threshold, suggests that severe infection, sepsis, and bacteremia are much less likely. Therefore, in this case, broad-spectrum antibiotics was not started as infection was not suspected. Patient's tachycardia was attributed to dehydration and AFib with RVR, and he was given IV fluids. In addition, he received rate control medication. His repeat lactate improved, and his creatinine eventually went back to his baseline. In the above scenario, patient improved and was eventually discharged from the hospital without the unnecessary administration of broad-spectrum antibiotics. So, patient presented to the emergency department and was admitted to the hospital, and the urine culture eventually demonstrated that the patient did not have a urinary tract infection. Without access to MDW, the first scenario would have likely led to initiation of broad-spectrum antibiotics that would have continued until the urine culture resulted days later. However, having access to MDW, which in this case was not elevated, prevented this patient from receiving unnecessary antibiotics for days. This concludes my presentation on the role of MDW as a pragmatic screening tool, decreasing probability of severe infection or risk of sepsis. Thank you.